All right. Okay, I'm sorry. Okay, nothing to disclose. Issuing Milan criteria proposed in 1996, more than 2 decades ago, especially established for DDLT and not considering tumor biology. So what are the ideal selection criteria in accordance with the current medical standards? Expansion of the criteria depends on availability of the grafts, impact on candidates without HCC, the expected outcome in terms of recurrence and mortality after liver transplant, and the type of liver transplant, LDLT or DDLT. Slide showed major expansion criteria for DDLT worldwide. UCSF criteria is morphologically expanded criteria as well as Albert's, although their expression is different. Hanzu criteria expand the tumor size up to 8 centimeters, but limited with the histology and the biomarker. Up to 7 criteria also limit the tumor morphology. Tront criteria limits from the tumor histology, and the Valencia limit with the tumor size. If you look at the outcome, 1-3-5 year survival, the comparative each other, 5-year survival was 70 to 80%. Should selection criteria of DDLT and LDLT be different? Yes, DDLT is public because the candidates with HCC had to compare with non-HCC patients. But LDLT is more personal, and no competition is there. In Japan, expanded criteria developed in major liver transplant centers. The selection criteria for LDLT and DDLT should be discussed separately. Regarding the difference between LDLT and DDLT, waiting time is shorter in LDLT. Pre-transplant milder is lower in LDLT. As a result, survival of LDLT is as good as DDLT, even better. In terms of recurrence rate in LDLT is controversial about the higher recurrence rate in LDLT because small size is one of the future factors to promote liver regeneration and tumor growth and recurrence. Also, there is a fast track to LDLT. Patients with LDLT undergo liver transplant might have aggressive disease. Some center has postulated that LDLT and DDLT have a similar recurrence rate. They say that because of the fast track to LDLT, candidates for LDLT had to be examined with the cancer clearance policy and requires liver biopsy to eliminate poor histology. If you look at the table, the Hong Kong group, 8-0, and the Burlington group revealed a higher recurrence rate in LDLT. One meta-analysis, including 13 studies, showed the lower recurrence survival rate in LDLT group. In French group and the Tront program showed a similar recurrence rate between LDLT and DDLT. The other meta-analysis showed no difference in recurrence rate in 2 groups, but higher recurrence rate was shown in LDLT who did not meet the Milan criteria. I talk about the evolution of expanded criteria of liver transplantation for HCC, focusing at Japan. A slide shows the annual numbers of liver transplantation in Japan. Green bar showed the LDLT, and the red bar showed the DDLT. Still, cadaveric donor is very scarce. Almost 10,000 cases are done so far, and of these, 30% of the adult cases are for HCC. At first, the major center made their own criteria based on their liver transplant cases. Although the diameter of the tumor size is the same 5 centimeter, the number of the tumors 5 to unlimited without the DCP values. Although the criteria are different among the three groups, results are almost same with survival of 80% and recurrence rate of about 5-6%. If you compare those three groups to other transplant centers worldwide, you will realize that the criteria in those four centers consist of morphology and biomarker. Criteria in those three centers include the histology of the liver. That means they do a liver biopsy. Puro biomarker and the liver biopsy are important for patient selection. To know the tumor biology, possible modalities are raised. First one is the liver biopsy to eliminate a poor histology. Second one is the biomarker, including AFP, DCP, NLR. That means the nuclear lymphocyte ratio, or LMR, lymphocyte monocyte ratio. And the third one is the FDG PET, and fourth, liquid biopsy in the future. Limitation is the liver biopsy has several complications, and the liquid biopsy is still too early to include in criteria. A best way to develop appropriate expanded criteria to use those biomarker and FDG PET. I will show you the paradigm shift in expanded criteria. We start with the Milan criteria at first, then examine criteria, expanded criteria morphologically. Now we are combined morphology and biomarkers. We select the favorable patient and expand the size and numbers above the Milan criteria. I will show two studies, national-wide multi-center-based and national data-based studies. At first, this is a multi-center study and to propose new criteria beyond the Milan criteria. New criteria consisted of a Milan and FDG PET criteria with a negative FDG PET and AFP less than 115, even exceeding Milan criteria. Recurrence rate is 8%. Dr. Hong also showed that the combination of the serum AFP level and the PET data predicted a better outcome than the Milan criteria. Even disease-free survival rate in the patient exceeding Milan criteria is 100%. This new expanded criteria is 3 steps from Milan criteria. I will show the national database study for expansion of the criteria. to establish the new expanded criteria, Japan criteria, satisfying 5-year recurrence rate within 10%, and maximizing the number of patients included. From 44 living donor liver transplant centers in Japan, 1,122 liver transplant patients collected between 1989 to 2009. Inclusion criteria are presence of HCC in the poorly liver transplant images and pathological confirmation of HCC in explants. Exclusion criteria are incidental HCC, macrovascular invasion, and elite transplantation. Primary endpoint, 5-year recurrence rate. Second endpoint is 5-year overall survival. A maximum diameter of HCC was set at 5 centimeters. Investigate the number of tumors and AFP cutoff value or DCP cutoff values, satisfying the upper limit of 95% CL of 5-year recurrence rate within 10% and maximizing the number of included patients. Best value of the number of tumor and AFP cutoff or DCP cutoff to recruit as many as candidates to keep a recurrence rate less than 10%. When you use the AFP for the criteria, best tumor number of 5 and best AFP value is 500. Recruited people are 725. When you use the DCP for criteria, tumor numbers are 4 and the best DCP value is 1,000. Recruited people is 708. Finally, we can recruit more people when you use the AFP. Final rule, the tumor size 5 centimeter, number 5 centimeter, and AFP 500, so-called 500 rules. Recurrent free survival within Milan criteria, 500 criteria, and the combined criteria are almost same values, with 71 to 73% in 5 years. The figure showed the recurrence-free survival of the subgroups combined with AFP and the new criteria. From the above, that one is within Milan within 500, and next one beyond Milan within 500, and the third one within Milan criteria and beyond 500, and the last one and beyond Milan and beyond 500. Each group were well separated, so those factors are very good one. When you use the new criteria, only you could recruit 11% beyond the Milan criteria, and the recurrent rate is 7.3%. If you combine the new criteria and the Milan criteria, you could recruit 19% beyond Milan criteria, and the recurrence rate is 9.1%. Combined criteria can give more chance to the patient, and the recurrence rate is less than 10%. It fits our criteria. In summary, the Japan criteria will expand the included number of patients by 11% when compared to Milan criteria. A patient with a Milan who are at high risk for HCC recurrence can be recognized by 500 rules. 500 rule can include patients beyond the Milan who are at low risk for HCC recurrence. It seems irrational to exclude those within Milan according to the new expanded criteria, namely the Japan criteria should be indicated for those beyond the Milan. it will expand the included number of patients by 19%. In conclusion, new Japan criteria 5500 rule is appropriate as an expanded criteria for LDLT among HCC patients. Thank you for your attention.